I'll now call upon Dr. Kavitha to present her talk.
I thank Dr. Srikanth sir for this great opportunity. And like cataract, now myopia has become really a well-researched, very much talked about and very much practiced and sadly mispracticed also all over the world, not just among pediatric ophthalmologists. So we want, as pediatric ophthalmologists and people who deal with children with myopia, to give some insight on how to approach if a patient or a child presents to us with myopia. So I'll just briefly go through how we as in an institute and how we should approach patients with myopia, like to reduce the burden of refractive surgery or at least bring the children to the level where refractive surgery at least is possible. That's what I tell the teens. If you want laser to be done for you, then you should control your gadgets and things like that. That kind of works. So this is what I'm going to try to explain. So there are some definitions we need to know when we talk about myopia. So what is primary myopia? So there are myopia which can be due to a lot of other conditions, and not all are amenable to these kind of measures that we are now talking about. So it should be primarily a primary myopia where myopia is not due to any cause. So it is either an axial myopia due to longer axial lengths or a refractive myopia due to changes in the refractive structures like cornea and the lens. What are naive myopes? Naive myopes are myopes at initial presentation. So they can present with -0.5 spherical equivalent. They can present with 2, but at presentation when they are diagnosed first time as a myope is when we call them as naive myopes. What are pre-myopes then? So a refractive state of an eye with less than plus 0.75 diopters, we kind of call them pre-myopes, especially in the background of family history of myopia, siblings with myopia. So they are kind of children where we should really pay close attention to. So they are called pre-myopes. So some more definitions. What is progression? So any change in axial length and refraction over time which can be demonstrable at a period of every 6 months or 1 year, we call it progression. And progressors are individuals with the mean rate of change of myopia exceeding 0.5 diopter per year or greater, and with corresponding axial length elongation of 0.2 to 0.3 mm per year. So progression in spite of treatment is a term now when failure of a chosen myopia treatment strategy to control axial length elongation happens. And cessation of treatment is again a thing which is still a big question. Nobody really has a consensus. So we don't know whether up to 18 we keep on doing or what. So when a child or a patient presents to us with myopia, so these are the things that we have to do. A baseline evaluation. History is important. Parental, family, onset of myopia. Behavioral practice is extremely important. Outdoor versus indoor, near versus distance activities, very equally important. Refraction, of course, whenever indicated, cycloplegic, central and peripheral refraction, best corrected visual acuity, both eyes, and binocular status. Accommodative function tests, Virgin function tests is important as part of myopia evaluation. Anterior segment and IOP to rule out other causes if present. Corneal topography sometimes can be done as a baseline, but not necessarily in all situations. And axial length measurement if you are going to treat myopia eventually. And fundus examination and imaging to document fundus changes if required. So when we say myopia, what are the risks of myopia? So there are some things which are called myopia inducing things, which is a 2% proven increase risk every extra hour of near work per week, any age. So lower vitamin D level is a controversial thing which sometimes can be inducing myopia risk factor. These are all patients who do not have myopia yet. Myopia protective, so as a corollary, yes, 2% reduction for every hour outdoor can have a positive protective effect on onset of myopia. So increased even indoor lighting can be protective for myopia in some context. So risk of progression is when there are already myopia as onset. So higher baseline myopia as compared to lower onset at the time of presentation. Younger age at presentation. Girl child has some more increased risk of progression. Excessive near work, of course, is well established. Reading at shorter distance, like we keep having parents tell us to read at a good distance, that is really extremely important. Parental history of myopia. Asian ethnicity, of course, again well proven. And defective accommodation and convergence, which sometimes we don't really look into this, but defective accommodation convergence, the combination complex is very, very important, and it can be a trigger for progression. And high ACY ratio, accommodative lag, because these situations children accommodate more and myopia can progress faster. And near esophoria, again to reinforce that good orthoptic evaluation is a must. So how do we stratify? What are the risk stratification tools? Are there any way to know, like if a patient presents, what to give or when to give? Or how do you assess? How do you tell the parents? Is your child going to, what will happen 10 years from now, 5 years from now? Is there an objective way to know? Yes, people have tried to study that. So there are some calculators called the Brian Holden Vision Institute calculator, which is online. So you feed in data like age, refractive error, ethnic data with and without treatment graphs. It gives you, if you treat myopia, what happens in the next 4 or 5 years. If you do not treat, what happens. So we can kind of give a guideline to the parents and for ourselves, and then initiate treatment. Like there are similar models with Chinese data where behavioral and environmental risk factors are included in the data, and you can give a guideline on what is going to happen if you don't treat. Like preceding myopia onset risk indicator, UK based, again you take into age, spherical equivalent, axial length, parental myopia. And myopia progress and risk assessment score, where you can classify children as at risk and low risk, and can be differentiated to decide on what modality we can suggest. Ultimately, individual private practice, our practice choice or what works best for us could be the best guide if you don't have all these strategies. So how do we approach a myopia? What are the strategies? So first is, of course, to create awareness. Second is screening the potential population to catch them early so that we can intervene early. The targeted population could be premature children, siblings and children of myopes, and children with excessive near work and less of outdoor activities. These are potential targets. So initial myopia progression control treatment. So when do you initiate a myopia progression control treatment? So there is still no consensus on appropriate timing. Do we start at the first visit, or what do we do? The above mentioned strategies can be applied to calculate whether they are at risk or low risk or high risk. Early intervention for patients with multiple risk factors like sibling history, parental history, close near work, outdoor activity less. So current recommendation is, in many situations, we start some form of myopia control treatment at the initial presentation itself in select patients. So how and what to choose? There are so many things now we are having. There are some of them are saying glasses, some of them are trip-ins. How do you choose? So there are spectacles, progressive, bifocals, ortho-K lenses, contact lenses. There is n number of this. So each speaker is going to tell us exactly how they work, but I'm going to rush through the types. So single vision glasses, most popular, very affordable, well accepted and tolerated. Under correction used to have some role, but now it is kind of not indicated. In fact, it's contraindicated. Bifocal glasses can reduce accommodation demand, and children with near esophoria and can benefit to some extent. Prismatic bifocals can also be tried. Progressives have been tried similar to bifocals and have noted control of progression of myopia. And now the current go-to glasses is the DIMS glasses, like defocus incorporated multiple segment spectacles. There are several options from this which we can choose. Significant retardation of axial length elongation in 8 to 13-year-olds have been well demonstrated. Comparable or superior to all other modalities except probably atropine, which is still superior. More useful in peripheral hyperopia if it is documented. That is where peripheral refraction comes as an important tool for myopia evaluation. And limitation in myopia limitation is when you have myopia between 6.5 and astigmatism less than -4, these glasses are effective. Beyond that, we don't have still options. So contact lenses as an option is not that popular in India because of climatic conditions, compliance and as such. Can be used above 7, especially children who are inclined to sports, daytime sports. This contact lens I mean by day wear contact lenses. There are other type of different types. Soft single vision contact lenses, no appreciable efficacy in controlling myopia progression, and risk of infection is there, so it's not very popular. Dual focus contact lenses like MySight contact lenses are getting popular. Myopic peripheral defocus it is based on. 8 to 12 years of age is ideal age when they are more inclined to sports and all that. And significant control of spherical equivalent is demonstrated, quite safe because daily disposable options are available, but costly. Ortho-K lenses is really effective in a very select group. Night wear contact lenses, so you don't have to wear in the daytime. Myopia control is achieved in higher initial myopes, especially more than 5.5 diopters, and it controls axial length prolongation. Rebound effect and risk of infection is again a negative factor. So atropine is going to be talked, extensively researched, most effective till date, widely used, 0.01% and 0.05% are the commonest used. Ideal to start after demonstrating progression and not at the initial presentation. Ideal age is above 6 and very safe, no consensus on how long do we continue. So follow up every visit, ideally 6 monthly, and you repeat all these tests to know the effect of the progression. So the algorithm will be myopia at presentation, baseline evaluation. If there is a low myopia, low risk, single vision glasses, lifestyle changes, and close follow-up, you don't need to start a myopia control method. If there is a high risk with family history and everything, all above, other than that, you can start on DIMS glasses. If you continue these patients and there is no progress, as long as no progress, you continue the same and follow up every 6 months. If despite this there is progress, then you switch to LDA and follow up. And if despite that there is progress, you do a combination of LDA and DIMS. If despite all this there is progress, then we call them as non-responder and decide to stop. If it is moderate myopia at presentation, then you can start with DIMS glasses, lifestyle adjustment, close follow-up, and rest of the follow-up continues. If there is progress despite that, you switch to LDA or add a combination. So this is how we kind of form an algorithm. So duration of treatment, like I said, there is no consistency, there is no consensus on how long to do, but 1 year to assess efficacy, whether to know whether myopia is actually the control measure is working, and minimum 3 years, whatever treatment you have started, you can continue before you decide to either continue if it is responding or discontinue if it is not responding. And cessation after 16 years or if there is failure to respond. And tapering if LDA is used, because there can be a rebound even in very mild LDA. So like I said, there is no clear guidelines yet. Reasons for failure is compliance related is the first thing, especially with LDA. You can switch to other modalities. Not adherent to lifestyle adjustments like near activity and sunlight exposure despite using the myopia control progress measure is another reason for failure. Ethnic reasons can be a reason, genetic predisposition, but sometimes we don't know why children don't respond. So this is a very good systemic review meta-analysis which everybody can go through to form guidelines on how to treat these patients. To summarize, myopia is easily the most researched eye condition in the recent past in children. Awareness has tremendously increased among patients, among parents come and ask us for the treatment. It is also the most mistreated condition in the recent past, so it is for us as pediatric ophthalmologists to guide the parents of what is suitable for the patients. And despite everything, we can now say that myopia is now a treatable condition even in children. Thank you so much.
Thank you, Dr.